Come back. Hi, afternoon, everybody. Thank you for joining us today for the talk about lymphoma. My name is Andrew, and I'm your host today. I'm also the counselor, the manager for the Psychosocial Services Department at the 365 Cancer Prevention Society. Before I walk you through today's talk, please like and share the video. And also, if you have any questions, comments, or encouragement, please also feel free to put in the comments below. We will have a FAQ sessions towards the end of the talk. We are very honored today to be able to invite two speakers for the talk today. First was Mr. Leslie Yong. He's a lymphoma cancer survivor. Second, we have Dr. Michelle Poon. She's a senior consultant at the Department of Hemato-Oncology, National Cancer Institute of Singapore. She's a program director for NUHS, Hematopoietic Stem Cell Transplant. Before the talk proper, please allow me to share with you about 365 Cancer Prevention Society. 365 Cancer Prevention Society, in short, sometimes we call it 365 CPS, is a non-profit organization. We are accredited as a full member of the NCSS. So some of you might be thinking, what does 365 stand for? Besides to good health, for 365 days every year, the 3 represents the trifold missions of our society: cancer prevention, cancer fighting, and cancer education. So how do we accomplish through our 6 core services? Within the Psychosocial Services Department, we have care leaders. We provide care and support through phone call or visitation, as well as financial support. Secondly, we have counselors and dietitians to provide counseling and nutritional support. Next, we have 3 social service centers. The locations are actually very easy to remember. They're actually as easy as A, B, C. A stands for Ang Mo Kio, B stands for Bukit Panjang, C stands for Clementi, which is upcoming in September. The exact locations, you can visit the website as shown below. So what does social service center do? They organize physical exercises, such as detox, restora, activities such as art and crafts, and lastly, health talks. So this is how we accomplish our trifold mission through our 6 core values. Without further ado, let us invite Mr. Leslie Yong. He will share with us about his journey, how he overcome his challenges, and how he sees at the present moment. Mr. Leslie, please.
Allow me to briefly introduce myself. My name is Leslie Yong, and
hi, Mr. Leslie.
So glad to be invited to share my rare encounter some 10 years ago. Back then, I often had rashes on my left cheek, especially when there's a very unpleasant situation arise. So I found myself visiting the dermatologist many times for checkups. Amazingly, each time the rashes would just come and go away as soon as they appear. After 2 biopsies, the doctor in the National Skin Center confirmed that I'm down with MF, mycosis fungoides. It is a rare form of cutaneous T-cell lymphoma, which is belonging to the non-Hodgkin type. And it really affected my skin on my left cheek. And it's very uncomfortable. Just to describe the rashes. All right, so he referred me to National Cancer Center to see an oncologist. Upon several visits, the oncologist finally confirmed that I need a radiotherapy procedure. So it was done, and the scary part was that After when it was done, I was so worried. I was so depressed. I become very, very worried because the patch of skin done for very deep red. So always I felt a burning sensation on my skin, right, on the left cheek. So I couldn't find any kind of alternative treatment except TCM. So in the depths of despair, I consulted the TCM doctor, and he told me that similarly, it is difficult, very difficult to deal with it. The only thing that he can deal with it, to help me deal with it, is to prescribe me something to take, Chinese herbs and medicine, but it doesn't really help. So I found tremendous support in the network that I have through friends, family members, and so on, ex-colleagues, and so on. And then I also found support spiritually through church. And I also find myself beginning to surrender my life to God and seek help, seek His complete healing. So after several months, or in fact years, I become better now, and I begin to live a normal life. So I also like to share with those who have been walking this journey, right? There's always a possible silver lining in every depressing situation like the one I've gone through. Furthermore, I find great joy and benefit when I somehow come to know about the 365 CPS, and I find that I have this kind of a hand-holding feeling whereby they are really giving this a pleasant treat to cancer survivors and patients alike. I attend many of their classes and activities. Just to name a few, they are love lunches, health talks, stretching exercises, singing classes, and ukulele classes. I even attended one of the excursion trips to Sabah, 9-day excursion trip to Sabah, which really helped me to change my outlook and be more joyful in life. I would like to give some pointers to those who are walking this journey right now. There are three things that at least that you need to take note of, and that is to have a daily exercise routine, whether it be in the morning or evening, be it walking, stretching, or to join a group so that you can exercise together, and to have to pay attention to your meals, eat wisely and eat rightly, have balanced meals. All right, if you can, do a lot of juicing. Next one will be sleeping well and have good moral support from the support that you can get as you build your own network among yourselves. So thank you very much. Now I shall pass the time over to the next speaker. Thank you.
Hi, thank you, Mr. Leslie. Thank you for sharing with us your journey and pointers. Indeed, eat wisely and having a good support is very important. So I hope today's participants, right, you can share some encouragements, or you have questions for Mr. Leslie, you can always put in the Facebook comment below, and we will answer some of the questions later on after the second speaker. So without further ado, let's welcome Dr. Michelle Poon. She's going to share with us today on exactly what is lymphoma, how does it affect us, and what are the treatments available. Let us invite Dr. Michelle Poon. Hi, Dr. Michelle. I think your video not on yet.
Sorry, I am technically very challenged. I thought my video was on though. I apologize, but my video is. Sorry, just give me a second. Y'all can hear me, right?
Yeah, we can hear you. Don't worry.
Thank you everybody for inviting me. While we are still trying to sort this technical aspects, let me see whether I can actually share my slide at least, so that let's see whether y'all can at least share my slide while we're trying to figure out how you can see my face.
Sure, no problem. Let me pass the mic on to Dr. Michelle now.
Okay, so I hope you all can see this. I'm really sorry for the technical difficulties. But I guess this is like medicine and life. Things suddenly happen, and then you just have to handle things the way they come. Okay, so the next talk is about how bad is lymphoma. Basically, I think the whole point of this session today is for me to give you an overview of what lymphoma is, a couple of slides, and then I hope after this session, maybe you all can ask me any questions that you all may have. So the first question is, what is lymphoma? And I always struggle to explain to people what lymphoma is. If you look at this is data from the Singapore Cancer Registry. You can see that lymphoid malignancies or lymphoma is amongst the top 10 cancers for both males as well as females. And yet it's so much easier to explain to people what is lung cancer, what is breast cancer, what is liver cancer. But try and tell somebody what is lymphoma, and for the always at the start of the consultation, I spend like maybe 10 minutes trying to get patients to understand what lymphoma is all about. So if I may try to simplistically explain, so our body has we have blood that carries oxygen to the rest of the system. There's also what we call a lymphatic system, which is part of our immune system. And the lymphatic system actually protects us against infection and disease. And it's also called the germ fighting network. And it's represented by these green vessels on this diagram. So in the lymphatic system, what are the structures that are part of the lymphatic system? You have the lymph channels, the vessels that carries these white cells around the body. You also have things called lymph nodes. And lymph nodes are found in the neck, under the armpit, as well as in the groin area. And other structures like the tonsils. And within these lymphatic structures, there are white blood cells or soldiers that help us to fight infection. So what happens in lymphoma is that the white cells within these structures actually turn cancerous. And that causes swelling of some of the structures like the lymph nodes. And that's when the patient is considered to have lymphoma. And like I think what you've heard from Mr. Leslie, he shared that he had a T-cell lymphoma, non-Hodgkin's lymphoma. And there's actually two main types of lymphoma, Hodgkin's and non-Hodgkin's lymphoma. The difference between the two lies in the white cell that is involved, the kind of white cell that turns cancerous. In Mr. Leslie's case, it was a T cell that turned cancerous. Sometimes it can be a B cell. These are just different types of white cells. And on the slide, what we do is that we take a sample from the patients and we look under the microscope. And you can see that this owl eye-like, I'm not sure whether you can appreciate my arrow, but you can see this owl-like structure. This is actually a Reed-Sternberg cell, and it basically, if you see this, it suggests that it's Hodgkin's lymphoma. Whereas below in this is actually a non-Hodgkin's lymphoma. You don't see this kind of cells present. So for the next maybe 10 or 15 minutes, I would just like to go through a patient's journey, and from the time of diagnosis till the time of management. Okay. So the first step, obviously, for a patient to actually present to the physician is normally because of some sort of clinical suspicion. For Mr. Leslie's case, for example, it was a rash that he noticed. And, let's look at what are the symptoms that can lead patients to come to see a doctor. Okay, so lymphoma, I think the main bulk of symptoms that our patients have are actually lymph node swelling. So as I told you before, lymph nodes are structures where the white blood cells reside. And when the white cells turn cancerous, these lymph nodes can swell. And they can be found under the armpit, in the groin region or in the neck area. Okay, and the patients can come in with a big swelling. Sometimes this may be found incidentally when they do an X-ray or scan for something else. Okay, apart from that, sometimes people can present with fever, sweating, and this is not just normal sweating, but really drenching night sweats where the whole bed is actually wet. They have to change their bed sheet every night. Other symptoms are spots. I think if you remember from Mr. Leslie's sharing as well, he did mention that he had rashes, and rashes is also one of the some symptoms of lymphoma. Other things are things like weight loss, loss of appetite, nausea, breathlessness, fever. So very non-specific symptoms. A lot of the patients who have rashes and swelling of the lymph nodes do not have lymphoma, but the bottom line is that it is necessary to consider medical consultation if you notice these symptoms, at least your GP to assess these symptoms. In addition, some patients present very acutely. They present with for example, if you look, this is actually a scan of somebody's spinal cord. So you can see this is the backbone, the spinal bone, and then this is the spinal cord. And I don't know whether you can appreciate there's a lump here that's starting to press inwards. And what happens to our patients is that this patient will be that he would start having back pain. And if nothing is done and this lump starts to press on the nerve, sometimes that can lead to paralysis. Another concerning, although rare symptom, is something called superior vena cava syndrome. So what happens is that this is the upper chest of a patient. You can see this is the lung, and this is the lungs, and this is the heart. And these are blood vessels that carries blood from the face and the upper limbs to the heart. And in patients with lymphoma, what happens is that sometimes there can be a lymph node swelling that grows. It blocks up the vessel and it causes slow, you can imagine, right? It's like ECP getting blocked up or PIE getting blocked up. The blood flow is actually blocked. And as a result of this blood flow being blocked, there is swelling of the structure. So patients may have present with very significant face swelling or blood vessels here because they can't get through. There is distension. The blood vessels become very prominent. Okay, and this is what we call superior vena cava syndrome, and it can be life-threatening. So definitely, majority of patients will present with something less emergent, but some patients present as something very severe. And if the doctors feel that there's something that is concerning, they will then refer them for more diagnostic tests. So that goes on to the next stage. So the next step when we are referred such patients is to confirm that the patient has lymphoma and to assess what's the disease stage before deciding on a treatment plan. So this is what we call histology. Remember I talked to you about Hodgkin's and non-Hodgkin's lymphoma earlier, and how to differentiate between them is to look under a microscope and look at the appearance of the white cells. But in order, obviously, to look under the microscope, you need tissue. Okay, so what we normally do is that we may stick a needle in to collect some cells from the lymph node, okay? Or sometimes there may be a surgery. We make a small cut to remove a lump. For example, if the lump is in the neck, we may make a small cut to remove the lump. And this lump can be put under the microscope to look for those cells that we talked about. If the diagnosis of lymphoma is confirmed, then obviously we need to stage patients. Staging means trying to decide whether is it early or stage 1 or very advanced stage 4 disease. Okay, and this is basically a PET-CT. So there's two components to a PET-CT scan. One is called a CT scan. CT scan is basically just a more in-depth X-ray that looks at the various structures in the body. Okay, so the lungs, the heart, you can see inwards. A PET scan, on the other hand, basically injects some sort of material that goes to areas that have high activity and lights up the area. Okay, so obviously your brain is working all the time, so you will have the brain that is lighting up. But in addition, if there are tumor cells, for example, the tumor cells are growing very fast and they can also light up on the PET scan. And therefore, you can see a white spot here that suggests something not normal. And in a PET CT, what happens is that you do a CT scan, you do a PET scan, and then you superimpose the images. So the radiologists can then assess, you see a dot here, what does it correlate to on the CT scan? And this is extremely important when trying to stage patients with aggressive lymphomas. In addition, sometimes some patients may need a bone marrow biopsy, where basically they lie either on their side or their back, and a needle is inserted into the hip bone, and some cells are taken out for assessment to see whether the cancer has gone into the bone. Because if the cancer has gone into the bone, it's considered stage 4 disease. But unlike breast cancer or lung cancer, as I always tell my patients, stage 4 lymphoma is still curable, is potentially curable. And we still, when we treat our patients, we are still aiming for a cure for the majority of patients. Okay, next we go on to management of patients, and there are many treatment modalities, including chemotherapy, radiotherapy, and targeted therapy. Okay, so we'll look at what we mean when we say targeted and non-targeted. So I think if you remember Mr. Leslie's talk earlier, he mentioned that he had gotten radiotherapy and that the skin around the area was actually red. And actually, the mainstay for a lot of the lymphoma is chemotherapy, but for some skin-based lymphomas, it can be radiotherapy. And I put this picture of a bone here not to scare people, but to just tell them that chemotherapy and radiotherapy is considered non-targeted therapy, or as the Chinese say, 没有长眼睛. So what do you mean? What do we mean when we say non-targeted therapy? So for example, if a bomb was set off right now and it was meant to harm, say, certain group of people, but the truth is the bomb is not going to say, when I explode, I'm only going to harm the people that I want to harm and spare the other people around. When the bomb explodes, both the normal and the targeted people and the other people around will all get affected. Okay, and that's what I mean by non-targeted therapy. I think similarly with chemotherapy is using drugs that kill cancer cells. Basically, chemotherapy is a drug that is very toxic to cells and causes dividing cells to die. And the reason why it targets cancer cells is because cancer cells divide very quickly, and so they are very sensitive to this chemotherapy. But the truth is, it doesn't really only say I only kill cancer cells and not non-cancer cells. It will kill any cell that divides rapidly. And so in our body, the cells that divide rapidly are in the hair and in the gut. So you can imagine, that's why patients get a lot of nausea sometimes, vomiting, diarrhea, and after the chemotherapy, and also they lose their hair, because the chemotherapy doesn't say, because you're a hair cell, you're not a cancer cell, so I'm going to spare you. It doesn't work that way. It just kills any cell that divides very quickly. Okay. For radiotherapy, the same concept. Obviously the radiotherapists will target the radiotherapy so that it doesn't affect the nearby cells. But the truth is, again, radiotherapy cannot just say, I only target the skin, the area of the skin where the cancer is, and the nearby skin, I'm not going to attack it. And therefore, that's why even though Mr. Leslie, after he had the radiotherapy, he would still have some redness of the skin around around the area. But most of the time, the healthy cells can repair and recover from the damage. And again, like I said before, the problems with chemotherapy and radiotherapy, they are not selective, they are not targeted. Both normal cells and cancer cells get damaged. As long as you're dividing quickly, you are at risk of getting damaged. And therefore, this explains all the side effects that happens with chemotherapy: nausea, vomiting, mouth sores, loss of appetite. Sometimes it can affect the heart cells as well. And so in recent years, there has been a move towards trying to get more and more targeted therapies to improve outcomes. So what are targeted therapies? So targeted therapies are therapies that target specifically the cancer cells. In this case, I put lymphoma cells, but in other cancers like breast cancer, lung cancer, there are also increasing use of targeted therapy. And targeted therapies are more selective than chemo or radiotherapy. And therefore, if you think about it, because they're only targeting the cancer cells, the non-cancer cells are not going to get affected. Therefore, it has less side effects and is very much more tolerable. And in what we sometimes call this targeted therapy precision medicine therapy. And so I took this photo of one of the blogs from Commando, and what I wanted to show is that if you think about chemotherapy and radiotherapy like a bomb that kills that doesn't have eyes and kills both normal and abnormal cells, then I think about targeted therapy like a commando squad, where you send them in specifically. You say, there is this terrorist in this area. I want you to go to this area and kill this terrorist. So they will go in a squad and kill the terrorists. The normal people in the surrounding area are not going to get affected or injured. Okay, so I think that's what targeted therapy is all about. Very precise, very focused, and not causing damage to surrounding structures. And targeted therapies can work in various ways. They can block or turn off chemical signals that tell the cancer cell to grow and divide. So therefore, the cancer cells don't get the signals and they die. Or they can change proteins within the cancer cells so that the cells die. So, and these are called small molecules. And a lot of these targeted therapies, they can be oral or they can be injection forms. Very, very exciting. In addition, there's new agents called immunotherapy, where basically the immune system is taught to recognize only the cancer cells. So the reason why a lot of people develop cancer is because their immune system doesn't recognize, can't recognize the cancer cells well. And what happens in targeted therapy is that you train the immune system to become cleverer to kill the cancer cells, or you train the immune system to carry some sort of toxin to the cancer cells, but not to normal cells. And that's the basis of something called immunotherapy. And, again, targeted versus non-targeted, both have their good and bad points. Targeted therapy targets specific targets within cancer cell, does not target normally dividing cells. So with targeted therapy, you don't lose hair, you don't get, you don't get the diarrhea and things that you get with chemotherapy. But there is still a role for non-targeted therapies, because at the moment, non-targeted therapies are still important to kill a bulk of the cancer. Okay, and so I had this picture because I thought, the future is very bright. For lymphoma, at least, I'm a hematologist, so I may not know so much about other kind of cancers. But I think for lymphoma per se, there's definitely a lot of good options out there. And every day there's new data that's coming out, there's new information that's coming out that shows how we can can get more precise therapy without causing harm to normal structures. And so, if just to recap again, today we shared about a patient's journey. We heard Mr. Leslie speak about his journey, and we see how you can make a diagnosis. What is lymphoma? How you can make a diagnosis of lymphoma? How to stage? How to prognosticate? And how to manage patients. Okay, so I hope that this sharing has been has been sort of helpful, and I'll be happy to take any questions. Thank you. I think you all still can't see me.
Thank you, Dr. Michelle. Yeah, we're having a bit of technical issues here. Dr. Michelle, maybe you can try off and on your camera again.
Okay, I think it's destined. You shouldn't see my face.
Yeah, or you want to try to relog again because we can't see your face, so it's kind of awkward to be talking alone here.
Log into screen right, is it? Again?
Yeah, maybe you want to relog the screen again.
Okay, so maybe for I'm trying to log in you can ask any other question. You can key in your question and I'll address it soon. Okay.
So thank you, Dr. Michelle. So while waiting for her to relog into StreamYard again, so maybe we can run through some of the questions and thoughts and comments that you have. Please feel free to put in the Facebook comment below. And good afternoon for those who have just joined us. I hope Dr. Michelle's sharing was beneficial for everybody. So now we have a better understanding what is lymphoma. So feel free to have any questions or encouragement. You can put in the Facebook comment as below. Yeah, so there was a question about post-chemo's lymphoma questions. Yeah, so while we wait for Dr. Michelle to come back. Yeah, hey, you're back. I'm so happy that you're back online with us. Okay, so there's questions by one of the participants. So the question was for post-chemo or post-HSCT lymphoma patients. How useful is the use of minimal residual disease? In short, it's MRD, ctDNA tests compared with the PET scan as indication of likelihood to relapse?
Yeah, so at the moment, minimal residual disease has been used for a lot of blood cancers. At the moment, for leukemias, acute lymphoblastic leukemia is there's a lot more data for it, and it's quite well established as standard of care for acute lymphoblastic leukemia, where we follow MRD, and if MRD starts to grow up, it's a sign that things need to be changed. For lymphoma, things are a little bit less clear. I think people are thinking that there might be, because it's more like a solid tumor rather than leukemia, which is more a liquid tumor. The role of minimal residual disease has been a little bit more controversial. Definitely, I think PET scan remains the standard of care for assessing disease status. For minimal residual disease, there's increasing belief that you can sometimes check the blood to look for certain circulating cell-free DNA and all that, to look for the cancer DNA that's present in the blood, but it's not real time. And I think lymphoma generally, the standard of care for assessing disease is still PET CT or CT scan. I hope that addresses the question.
So we hope that you managed to address the question that you asked. So next question, Dr. Michelle, although you mentioned that the rashes can be generalized, general rashes. So there's a question posed by Joanna. She asked, Dr. Michelle, the rashes, can it be at any part of the body?
You mean for cutaneous lymphomas? So I mean for cutaneous lymphomas, yes, rashes can be anywhere. And sometimes they may not, you can, if you hear Mr. Leslie's story, it's clear that it took a while before the diagnosis was made. Cutaneous lymphoma is always sometimes challenging for the diagnosis to be made, and it can be anywhere.
Okay. So I hope we answered that question. So next question. One of the also common question that was usually been asked. Are my family members at risk of developing lymphoma if I have lymphoma?
Yes, so that's a question that a lot of people ask us, not only for lymphoma, but for other like leukemias and all that. And the truth is, for lymphoma per se, there's been a lot of research done over the years. It's never been clearly proven that it is a genetically inherited disease, unlike some other cancers. And so my simplistic answer to that would be no, although there's still a lot more research ongoing. But so far to date, it's not considered a genetically transmitted disease.
I see. Okay. So next question. For follicular lymphoma, is it better to wait and watch for symptoms before treatment or have treatment upon diagnosis? This question was being asked by Miss Jennifer Wong.
Yeah. And I guess for the rest of the audience who may not be so familiar with follicular lymphoma, so follicular lymphoma is a kind of non-Hodgkin's lymphoma. So follicular is a non-Hodgkin's lymphoma, a more slow-growing type. And so normally, for us at least, whether to treat follicular lymphoma or not depends on whether patients have symptoms, because there have been clear studies, good quality evidence that has shown that if you have no symptoms, and when I say symptoms, I mean things like weight loss, fever, night sweats, those things that I mentioned, or bulky lymph nodes that are causing potential risk of those emergency symptoms. If you don't have those symptoms, then there's actually no urgency to start treatment. And actually starting treatment early versus waiting until you have symptoms, there's been clearly shown in multiple studies that there's no benefit in starting treatment early. So in fact, a lot of these follicular lymphoma, we would suggest to just watchful waiting, see your doctor regularly, and at some point, if symptoms develop, we will start treatment.
I see. Okay, let's move on to the next question. Why do oncologists start patients on non-targeted therapy? First, since targeted therapy is less harmful to body and less effective. This answer is asked by Sweeping.
So the question would be whether should oncologists start targeted therapy first?
Yeah, since targeted therapy is less harmful and has lesser side effects.
Yeah, so actually, if you look for lymphomas, non-Hodgkin's lymphoma, the B cell type, not the T cell type like Mr. Leslie, for the B cell type, we already start targeted therapy in the initial treatment, but it's targeted therapy with chemo alone. Because at the moment, targeted therapy, whilst being developed, is still not good enough to completely replace standard therapy. So the treatment in the past, it used to be just chemotherapy alone, a kind of chemo called CHOP chemotherapy. Now people have added an antibody or immunotherapy called rituximab CHOP, where basically there's an antibody that identifies the cancer and then it binds to the cancer so that the chemo can kill the cancer more easily. The chemo and the body's immune system can kill the cancer more easily. And with the use of rituximab, if you look at the survival for lymphoma patient, it has improved overall survival for cancer patients. So at the moment, with all the research and development going on, targeted therapy actually is slowly going to first line, but it's still a work in progress. And at the moment, non-targeted therapy, unfortunately, even though it has side effects and all, it still remains the best form of treatment. But I foresee that maybe in the next 10 years, 10 years down the road, 5 to 10 years down the road, there may be some change in this practice.
I see. Okay, so that's actually a Chinese question. I'll try to translate into English. She actually asked, 请问医生有什么感觉对这个病情? I think she's trying to ask, let's say, how will you actually feel if we have lymphoma? Does blood test indicates that one might have lymphoma? Is it sufficient?
I mean, I don't know. I interpreted her question as asking what do I think about the cancer per se, right?
Like if they have lymphoma, how would they feel? You know, like, or is it blood test? Is it sufficient to indicate that one has?
Blood tests can certainly sometimes make you suspect lymphoma. For example, if the blood count start to drop, if the cancer affects the bone marrow and the blood count start to drop, or sometimes patients like the follicular lymphoma question by Ms. Wong. The truth is, a lot of times, sometimes patients may not have any symptoms, and it's something that is incidentally found when you go for a health screen and you do a blood test and things are found. My interpretation of the question in my Chinese was that she was asking me what my thoughts are on lymphoma. And my thoughts on lymphoma is that it's one of those cancers where you can be stage 4 and you can still be potentially curable. And then you have indolent part of non-Hodgkin's lymphoma where you're not aiming for a cure because it's a very slow-growing lymphoma. And then people get nervous when you say follicular lymphoma. You say, oh, you can't get rid of the disease totally, and people get nervous. But the truth is, indolent or slow-growing lymphoma is actually a bit like diabetes and high blood. I was having a chat with Mr. Leslie earlier, and basically that's what we were discussing, that a lot of these indolent lymphomas are like diabetes and high blood. People don't get nervous when your doctor tells you got high blood. I'm not going to cure you of high blood. But when people hear cancer is not curable, it seems like a death sentence. But the truth is, a lot of this indolent lymphoma, it just goes on very slowly. You might not need treatment. And when you need treatment, we have very good treatment for that. So I think it's important to let our patients know that non-curable doesn't mean it's a death sentence. It just means like it's a slow-growing disease that just needs to be monitored.
I think definitely we can comparable as chronic illnesses like what Dr. Misha has mentioned, like diabetes, high blood pressure, cholesterol. So now and before, there's a huge difference lah. Okay.
I assume that was what the question meant, I must say.
We try our best to translate to English as well. So 希望有回答到你的问题。So next question, Dr. Michelle, hi. Is there a medications to prevent from swelling after removal of lymph nodes on the arms? I think this is a pretty common questions when patients, they have removed lymph nodes, especially on the arms.
Yeah, I must say the honest truth is for lymphoma patients, they are less likely to get this swelling or what we call lymphedema compared to other cancers, because the truth is when we are doing a biopsy or diagnostic biopsy to confirm lymphoma, we only take out one node, and that normally doesn't cause arm swelling. I know that for breast cancer, for example, sometimes they may have to do a lymph node dissection where they have to take out all the lymph node in that area, and that may cause hand swelling. And I believe that sometimes after the procedure is done, they may have to consider if there's arm swelling, they may refer them to lymphedema clinic, for options to help to treat that. I must admit I have very limited experience with lymphedema because my patients don't get the arm swelling because we only take out one lymph node, not the whole thing.
I see. So so there's a comment by Jennifer. So she would like to thank you for assurance. Sometimes it does feel like a time bomb. After your explanation, it is a relief to her. Let me see what she asked. So just now she was asking about follicular lymphoma. Was it better to watch? So after explanation, it gives her a lot more assurance that it doesn't feel like so much like a bomb.
Yeah. Because there are a lot of good treatment out there for follicular lymphoma now. But even though as doctors we really want to obviously when you tell somebody, no, we're watching you, it seems very scary. But the truth is, it is actually perfectly fine to watch because the data clearly shows that watching rather than jumping in to start treatment early. Sometimes watching, or what we call masterly inactivity. So, you watch 按兵不动, just watching is actually something good for the overall care of patients, because you don't need to start chemo until you have to. And some patients can go for 10 years without needing any treatment.
Okay. So next questions, probably due to the time constraint, we may not be able to answer all questions, but we'll try our best to answer most of the questions. So maybe we can accept 2 or 3 more questions for now. So there was a question here. Let me see. Thank you, Dr. Michelle, for the detailed slides. According to the studies, the participant would like to know what kind of age range for patients who are usually diagnosed with lymphoma.
So I, in the interest of time, I didn't go through very much of that, and that's a very interesting question. So if you look at, previously we talked about Hodgkin's versus non-Hodgkin's, and actually Hodgkin's tends to affect younger patients, whereas non-Hodgkin's tend to affect older patients. So Hodgkin's, we would say the age range is maybe about, even the really young ones, 20 to maybe about 30 plus, 40, whereas non-Hodgkin's tends to affect the older patients, 50, 60, yeah. But obviously, do I have like 70-year-old with Hodgkin's? I also have. But if you're talking about common things, the Hodgkin's tend to affect younger, non-Hodgkin's older patients.
I see. Okay. So next question. Okay. There was this question asked by Jessie. So, she mentioned that she feels some pain below the chin when pressing it, but can't feel any lump. Is it okay to wait and see for any symptoms, then seek treatment?
Yeah, obviously, the problem with all this feeling is that sometimes, the feel. I mean, these areas are difficult to feel. Even and sometimes it might, if you feel that the symptom is quite significant or quite prominent or quite persistent, it might be good to just visit your GP to let him examine you. Because obviously sometimes you may try to feel, but if it's quite deep, then it might need an experienced pair of hands to actually feel the lymph nodes. And obviously trying to feel on yourself, that the angle is also a bit difficult as well. So I would suggest, if the symptoms is less pain or discomfort, then to consider getting a GP to just have a quick check.
Okay, we hope we answer your questions. So perhaps we can have one more questions. So there was this question asked by Brenda. Will patient get jaundice with lymphoma?
Yeah, definitely. I mean, if you look at the symptom of lymphoma depend, apart from the fever and the night sweats and the weight loss and the usual, what we call systemic symptoms, the general symptoms, there's also symptoms caused by obstruction. So basically, I'm frozen on the screen, but that's all right.
Yeah, it's okay.
It can cause obstruction of the various structures. So if you remember my picture of the man with the swollen face, that happens when it blocks up the vessel in the chest region. Similarly, if it blocks up the blood, the gallbladder's outflow, or blocks up the flow of the green material called bile, then patients can get jaundice. Yeah, so the simple answer is yes, they can get jaundice. In fact, then when the structures are bulky and they press on various structures, they can cause different kind of symptoms.
I see. Okay, there's another question. Yeah, the video is recorded, so you can always come back and fall back to the video later. Yep. Yeah, you're kind of frozen. I guess online social media is like that. So probably we can cater to one more last questions. For post HSCT lymphoma patients, should a patient be on maintenance therapy or immunotherapy drugs? And how many months or years?
Yeah, so it's a very good question, and the honest answer is that it depends on the type of lymphoma, because there are some lymphomas where maintenance has clearly shown to be beneficial. For example, non-Hodgkin's lymphoma, mantle cell lymphoma, maintenance has clearly been shown to be beneficial. For other kinds of lymphoma, like another kind of non-Hodgkin's lymphoma called large B-cell lymphoma. There has been good quality evidence to suggest maintenance has no benefit. And of course, the simple concept is that let's give more is better. But the problem is with giving all these medicines is that they also have side effects. So generally, we would look very carefully at the literature. And the good thing is because lymphoma is so common, there's so much literature out there, and we would give maintenance based on if there is good quality evidence. Good quality evidence meaning randomized studies, randomized controlled studies that compare no treatment versus treatment and show good outcomes, then we would consider treatment. But if it's just based on very limited quality evidence, then we wouldn't. And so the decision will depend on, number one, the type of lymphoma, and number two, the response after the transplant.
Okay. We hope that Dr. Michelle's explanation did answer your question. Although she froze, but luckily the voice is still there.
So it's important to also discuss it with your physician, because obviously different cancers have different needs for maintenance. Some maintenance doesn't help and some maintenance helps.
Yep. Okay, so probably that is the last question that we can cater. So if there's any questions we are unable to answer you, feel free to comment below. We will get back to you offline. Maybe we can answer. I'll get Dr. Michelle maybe to answer some of the questions that we weren't able to answer today due to the time limitations. So we would like to thank Dr. Michelle again today and Mr. Leslie for sharing lymphoma, their journey, challenges, and how to cope. So a lot of times, right, a cancer diagnosis can be overwhelming. So thus, finding someone to talk to is actually very important, where you can share about your fears, your hopes. This someone could be a friend, your family, your care leaders, counselors, or even cancer support group. So thank you all today for spending time with us. So before we end the talk, I'd like to announce the next talk, which is on the 18th of August, 11 a.m. The talk will be about the benefits of fruit juice. The speaker will be Miss Anna Phua. So it's at 11 a.m. So before we end the talk today, please like and share the video so it actually can benefit a lot more people, so they can understand what's really lymphoma. And let us put our hands again to thank Dr. Michelle and Leslie to come on board today to share with us their experience and what is lymphoma again. So we will see you on the 15th of August. Thank you for everybody. Goodbye.